afternoon. I am going to go ahead and record this meeting and let Adam get started so we have all of the presentation time.
Awesome. Well, thank you so much, Amanda. There we go. Okay. Thank you so much. And um, good morning, I guess. Afternoon, kind of right on the cusp there. Everyone, again, Adam Novak, Director, Safety and Quality at the MHA Keystone Center. And as Amanda mentioned, we did a presentation on workplace violence, some of the stuff we're doing at the Keystone Center, and maybe some of the ways you could get engaged a little while ago, a couple months ago, and decided to do kind of a part two. So I'll be recapping part one and then go into some more detail on how you all, as members of the MHA, can get engaged in this kind of work if you would like to, if that fits your organizational needs. So happy to be back. And if you were in attendance at part one, a few of these slides might look the same, but again, the primary purpose of this part two will be to dig down a little more deeply, specifically into the funded work that we have. So these would be things that are available to you all free of charge. And I'll explain a little bit more about that throughout the presentation. But just to kind of provide some context for what we're talking about today and sort of the scope and the scale of workplace violence in healthcare, I'm going to go through a few data slides here. And this first one is from the U.S. Bureau of Labor Statistics. And just an FYI, too, a lot of the slides that I'll be going through today in the lower left-hand corner, you'll see a little hyperlink. So I've tried wherever possible to link to the sources of the data, or if it's discussing a business partner that we're working with or a vendor, linking to their website in case you want to learn more about them or would like to directly inquire with them, you can click those links and go there. So just wanted to draw your attention to that before getting started. But this is a data slide. It's actually very commonly cited as well. You'll see this all over the place. If you read articles on workplace violence in healthcare, a lot of times, if you look closely, they will be referencing this data chart. And it's from the U.S. Bureau of Labor Statistics. And basically, the main takeaway here is that healthcare workers are disproportionately affected by violence compared to all other industries or fields. And so you can see here clearly, I've gone ahead and thrown in the percentages, but in 2018, which is the most recent data they have in this trended data chart, almost 3/4 of all violent injuries in any industry, in any field in the United States in 2018 happened to a healthcare worker. So it happened in healthcare, 3/4. So that right there should tell you that we have a huge problem on our hands. And I believe, too, that the U.S. Bureau of Labor Statistics updates this data, I want to say every 5 years. So we should be due for an updated data chart in the very near future. So excited to see what that looks like. And then to further break down that data, again, this is from the same source, US BLS. This is looking at the most severe types of violent injuries or most severe outcomes from a violent episode in healthcare, which would be death or a homicide, broken down by the relationship between the victim and the perpetrator. And you can see here that about 1/3 of those fatal violent episodes in healthcare are perpetrated by a relative or domestic partner, about 15% by a patient. And that'll be, hold on to that patient data point, if you will, just in your own mind. That'll be important in several slides here, and I'll point that out. And then about 13%, or just over 13%, kind of lateral violence, if you will, or coworker to coworker, work associate, et cetera. So that's kind of a breakdown of, what we're looking at in terms of violence in healthcare and who's committing this violence mostly. A couple other studies I wanted to draw your attention to that I put in here. In 2022, Press Ganey did a study and found that 2 nurses are assaulted every hour in healthcare in the US. So this is recent data. Again, 2022 is when it was published. So essentially by the end of this webinar, this office hours session, somewhere in the US, 2 nurses will have been assaulted. And then also in 2022, so again, recent data, National Nurses United, an organization called National Nurses United, did a study and found that there was a 119% increase in workplace violence against nurses since March 2021. So over roughly a 1-year period was the study timeframe, and found that certainly in the throes of the pandemic, violence went up specifically against nurses by more than 100%. And just a reminder too, there's multiple levels of harm that take place when violence occurs, right? So there can be physical harm, there can be psychological harm. And then if you look at things from a risk management perspective, enterprise risk management perspective, that is, there's the cost as well. And so we're already in a staffing shortage. It's a crisis. We're well aware of what's going on with that. There was mass exodus of much needed staff in healthcare away from the field. And so just pointing out, again, the average cost, and it fluctuates depending on what source you're looking at, but roughly the average cost to replace a nurse is between $35,000 to $45,000. I've heard upwards of $60,000, but again, these were just some of the data sources that I found and pulled from. This data slide is looking at the MHA's OSHA recordable incident rate data that we collect. So it's voluntarily submitted to us by you all, by Michigan hospitals. And you can see here that we've plotted out since 2017 through 2023 so far. And that data stat for this year is still being updated. So it kind of fluctuates a little bit as data comes in. But you can see starting at our baseline around, 2020-ish, it's gone up each year. So recordable incident rate, it's written up above in the header of this data chart. But what that translates to is incidents per 100 full-time staff. So that's the OSHA recordable incident standardized rate. And it went up, you can see 20 to 21 by 13%, and then 15%, and then actually a larger 33% jump was the most recent one. So this is something we're continuously tracking and using this data to drive our improvement efforts that we'll talk about here in a few slides. So when we look at, again, the cost of staff injuries, the one thing I wanted to point out here, because we look at multiple types of staff harm, right? It's not just violence, but when we look at violence, you'll notice, okay, the recordable incident rate is one of the lowest, and the cost associated is one of the lowest as well. However, we know that violence is heavily underreported in healthcare, especially non-physical violence. So if it's verbal assault, which we do define as a violent act, if somebody uses a derogatory term or a slur or swears at a staff member or threatens them, certainly verbally, those are all acts of violence and should be recorded and analyzed and assessed internally. But we're also asking that members who are submitting their OSHA incident rate data to us submit that information as well. Now, that's the ideal state. It's certainly not reality. So I can say with a fair amount of confidence that probably this 0.44 incident rate, and this is from 2019, is likely artificially lower than what reality would be. So I did want to address a couple things before specifically going into our partnership with Blue Cross Blue Shield of Michigan, which I had mentioned in part 1 of this webinar mini series, if you will. So before going into that, what's funded and the types of activities that we do under that work in partnership with Blue Cross, I did want to address these House bills that were recently signed into law, raising the penalties for an assault against a healthcare worker in Michigan. And you've probably seen some headlines about this and maybe some postings from the MHA. I know Governor Whitmer was at Sparrow Hospital main campus to sign these into law. So just wanted to address these and kind of go over what this means for you all. And so, again, it increases the penalties for assaulting a healthcare worker in a hospital or behavioral health hospital. It was passed with broad bipartisan support, which is always a good sign that this was not a heavily divisive issue just on the surface level. So that's a good thing. It did have widespread support. And there are some implications for what you all will need to do that's outlined within these laws, and that includes things like providing adequate signage that informs people coming into your organization of the penalties and of the standard of violence will not be tolerated, things like that. And we do have some resources to help you with this, as well as some education requirements for staff and for again, a lot for the public and those coming in to the organization to inform them of this. It will take effect March 5th of next year. And the one contentious issue coming out of this, and I'll explain a little bit more about that, is that it does not apply to patients. So if a patient assaults a healthcare worker, and I asked you if you remember to hang on to that statistic of the percentage of severe injuries, essentially death, homicide injuries, what their relationship was to that healthcare worker. About 15% were patients, and you can see it does not apply to patients. So if a patient assaults a healthcare worker, it's still just the normal law, not increased penalties. If it's a visitor, a family member, somebody else coming into the hospital who does assault a healthcare worker, that's when the increased penalties occur. And the explanation that we were given for why patients were not included was because, according to those who opposed including patients in that category in this law, according to them, it was because there's a lot of behavioral health patients and different issues in terms of mental capacity of patients and other variables that could impact that. And so they didn't want to increase penalties for those who may not have had full volitional control of their actions. Now, the MHA fought that. Ultimately, it still was not included in the law. So I did just want to point that out. It's unfortunately the reality of the situation of the laws that were passed, but did want to point that out, that it does not currently apply to patients. But looking at these two House bills, or now laws, what does it actually mean? What are the numbers if you were to read through them and kind of distill down all of that jargon? And so House Bill 4520 addresses assault and battery, and that would be a misdemeanor. So again, if this is, let's say, a visitor in the hospital assaults a healthcare worker, it would be a misdemeanor, and it could mean up to 93 days in jail or $1,000 fine. So that $1,000 is doubled from what it would be if this just happened out on the street. It would be a $500 fine. Now it's a $1,000 fine. House Bill 4521 addresses a more egregious crime, assault with a dangerous weapon without the intent to murder. Otherwise, that would obviously be attempted murder. So assault with a dangerous weapon, it could be really anything, a bat or a club, or they list a few different things in the law if you go and read it. But without intent to murder, that would be a felony, up to 4 years in prison, or a $4,000 fine. So again, normally if this were to happen out in the street, $2,000 fine. With the increased penalties now against a healthcare worker in a hospital, it would be up to a $4,000 fine. So, and I did link these two laws here. So this goes straight to the Michigan website, state of Michigan website, where you can read these. And I would encourage everybody to read up on these because, again, there's some things written in there about posting signage, posters, etc. And you can see this is one of our posters actually that I've taken a screenshot of and put on the right-hand side of the screen. A couple other things to mention. So again, we do have these posters available to you for free. So they're available to MHA members free of charge. You can put in an order online. I've linked that there. And that just takes you to our website order form. I will mention that these posters, since the signing of these bills into law, the posters have been updated with new language on them. So I actually haven't seen them yet, but I was told by our communications team they have been updated, and they did reduce the number of different kinds of posters you can get. So you see a lot of different styles and looks to these posters here. They did distill this down to just a few different posters now, and that was mostly due to low request numbers for some of the posters. And then the ones we did keep were the most popular ones. We were getting orders filled all the time for those ones. So just an FYI there, if you go to the order form right now, probably some of these will not be available. So just wanted to explain that. But that is a resource that you can go request and order right now, free of charge, in fulfillment of those new laws. And then there will be more information coming out on how you can use these, on how you can access other resources as well to maintain compliance with those laws. So that will be coming in the future from the MHA. Okay, so again, before going into specific Blue Cross workplace violence efforts and some of the things we're doing and the funding available to you all, I did want to touch on just a few other worker safety related efforts that we do currently have available to you. So one of them, and I feel like I talk about this on every call, so you've probably heard this a million times, but it's a great resource available, again, free to you, to all of your staff, and that's the WellBe work. So it's well-being improvement work. We're partnering with Dr. Brian Sexton. Some of you may be familiar with his 3 Good Things efforts that are pretty widely published over the last several years. So we're partnering with Brian Sexton and his team at Duke University to bring this for free to all of you. It's a grant that they acquired at Duke and decided to partner with the MHA to bring this to healthcare staff. So to date, I believe we have had more than 6,000 frontline staff within Michigan go through these modules and this training, if you will, this wellness training. And it's just sort of an ongoing effort. So you can go back and you can still sign up for this, and you can still watch recordings and get all of that great information. So with that, I did just want to mention that what you see on the screen here, this is a flyer for a 12-month series that I actually just concluded. So again, it started about a year ago. It was one hour webinar per month for the last 12 months, just finished up and concluded. However, all of the recordings, including being able to obtain your continuing education credits, they have nursing credits and medical credits for this, as well as each one of these webinars comes with a tool, a relevant tool that you can use and put into practice that is germane to the topic being covered. All of that is still available for the next year. So that's part of the sustainability model, is that even though the live part of this 12-month series has concluded, it's all still available. So you can still send out this flyer. You can use the QR code to register, go back through, watch all of the webinars, claim your CEs, and most importantly, get the benefit of the content. And I will show a data slide here in a second that demonstrates the efficacy of this work. One thing that is upcoming that will be live, that's free and available to you all beginning in 2024, is called WellBe Essentials. So basically what this is a pared down version of the most impactful of the 12 webinars. So I mentioned the monthly, year-long series just concluded. Of those 12, Brian and his team at Duke took the 5 most effective ones that they've seen in terms of impact on resilience and impact on emotional exhaustion and burnout, and put them into a little package called the Well-Be Essentials. And so what it is 3 times throughout 2024, they'll pick 1 week where they will do one of those 5-hour webinars consecutive days. So think of just one business week, Monday through Friday, each day over the lunch hour Eastern time. They will do a 1-hour webinar with that important content in it that will be live. And again, you can claim a CE for each one of those. And this will happen 3 times throughout the year. So right now it's scheduled to begin in January of 2024. And then there will be another iteration of that in May and another one in October. And that is free to you as well. And so I've included that screenshot here of this flyer with the QR code and the bit.ly link that you can go to register. And the cool thing is when you sign up for this and register, you actually do a little 5-question emotional exhaustion survey up front. This is how they collect their data. It's completely anonymous, though. They don't know who it is, whose data it is. It's just all kind of aggregated together. But the nice thing is that immediately once you finish that 5-item questionnaire, it gives you an emotional exhaustion score, kind of like a burnout score on a 5-point scale, and then tells you how you compare against the entire study group. So it might say on the 5-point scale, let's say 5 is absolutely burned out, and 1 is you're doing great, you're completely resilient, you have all the tools at your disposal to keep functioning even when times are tough and stressful and things of that sort. And it'll tell you you're a 3 or you're a 1.5, and then give you a scale that the median is 2.3 or something like that, and it'll interpret it for you and tell you what it means for you. So there's already a benefit, even if you don't even attend the first live webinar or module. So it's a really great resource. I would definitely encourage everyone to at least check it out. And then here's the data slide I was referencing. So this was after our initial series of Well-Be, and we did it at that point in time with more than 5,000 participants, and Duke did a pre-test, post-test study design to measure emotional exhaustion. Again, basically think of that as burnout, and found that there's a 20-point decrease in emotional exhaustion in the study group from before they went through these modules to afterwards. So it has a profound effect and a long-lasting effect as well. So it's not just a feel-good kind of thing. It actually has outcomes and produces results. So certainly take this to your staff, send out the information, and get them registered if you'd like to. And then the final thing with regard to our partnership and relationship with Brian Sexton and Duke, and I do want to point out, I put it in the last bullet on this slide, but this is not covered by the grant that Duke secured. So this would be a separate, if your organization decided to take advantage of this well-being leadership coaching that I'll talk about in a second, that would be a separate paid contract with Duke. So I did want to point that out, but I felt like it was kind of a neat thing to throw in here. I think the concept personally is pretty cool. But it's a leadership coaching cohort or series for leaders. So it's not just executive leaders. It's any leader of people. You can think about it like that. A manager, anybody who has direct reports, this could apply to. And it teaches skills that leaders can use to impact the well-being of their staff. So it helps with the soft skills. And basically the format is you get on this call with these coaches from Duke. you learn a new skill. They teach you in the moment, in the live webinar, a new skill. You practice it with each other, and then you get feedback on how that went. That's kind of the model that this follows. And the cool thing about this too is that you're cohorted with others from your organization. So it's really a team-based type training. It's not going to be someone from system A paired up with someone from system B. So it's kind of a team approach to learning these skills and being able to employ those with your staff members. So wanted to just throw that in there. Okay, so let's talk a little bit more about the Blue Cross work that Keystone has been doing over the last couple of years, some of the activities that are funded through that partnership, and then what that means for you all and how you can get involved. So just a little bit of background. A couple of years ago now, the Keystone Center entered into a partnership with Blue Cross Blue Shield of Michigan, where they are providing us with funding over the course of about 4 years to address several areas, strategic areas of improvement in safety and quality, and those being workplace violence or workplace safety, I should say, generally speaking. Obviously, workplace violence is one of those, as well as maternal health and opioids. So today we're going to be focusing specifically on worker safety, and within that, under that umbrella, workplace violence. So one of the activities that we've been doing for the last year or so, and I think I saw a couple individuals on the line that their organizations may have taken advantage of this already, so would welcome feedback at any point on any of your experiences with any of these offerings. But we've been working with an organization called Healthcare Safety Services. Again, it's linked in the lower left. And I just put a picture of their logo here in the middle, but on workplace violence gap analyses. So what are these? These are analyses where the team from Healthcare Safety Services will go into your organization physically, and they look at the structure of your violence prevention programs, your committees or teams, looking at it through the lens of, do you have a robust workplace violence prevention program? And specifically, I'm kind of jumping around on the slides here a little bit, but specifically looking at it through the lens of the Joint Commission standards. So requiring, trainings at various intervals, if there's major turnover, et cetera. What is involved in your workplace violence prevention program, and how can you improve it? And so that's what these gap analyses help to do. You end up with a comprehensive report where you can look at some low-hanging fruit, areas of opportunity, and some recommendations for improvement. So again, this looks a lot at the culture. This team interviews the staff. They interview leadership. They walk around the premises. They almost do like a Gemba walk, if you know what that is. And so they go to the people and the staff and try to figure out what are some barriers, what are some sticking points. Do people feel safe? How could there be improvements made here? What are the needs of the organization and the staff at various levels? And so, again, focusing on things like de-escalation strategies. Are these being taught? Is there education for staff? All, once again, in alignment with the Joint Commission standards. So this has been a great effort so far. We've actually received some wonderful feedback. This is a quote I wanted to share from a hospital president that recently concluded their first gap analysis at their first hospital. They're actually part of a system that's going to now roll it out to the rest of their system. But this was basically a pilot study. They wanted to try this at one of their hospitals to see if they liked it, see if they wanted to move forward with dedicating resources and time and energy to this work. And Ken, in this quote, Ken is the main team member, the leader, the founder of this organization, Healthcare Safety Services. He's fantastic to work with. And basically this leadership member was just expressing their gratitude for how it was so well received. The staff thought it was fantastic. It was very well received by the staff, frontline, mid-level management, leadership, everyone across the board. They gave a great report that was readable. So it's not death by paper. They don't give you a 1,000-page report that you have to thumb through for the next 2 months. It's very broken down into succinct recommendations and findings. So that's the feedback that we've had so far from Healthcare Safety Services and doing the gap analyses. So this work is funded under Blue Cross. And at the end of this presentation, there's a slide on how you can get involved, how you can request more information on this. So I'll get to that as well. Okay, so moving along, another business partner that we're working with, and actually an endorsed business partner of the MHA, which is sort of an official stamp of approval from the MHA. Basically, if you're part of our endorsed business partnership, what that means is that you've been vetted through one of our special committees within MHA that looks at all the offerings that an organization or third-party vendor has, and if it seems valuable and beneficial to our members, then they can enter into our endorsed business partnership program, and they then become sort of a preferred partner, if you will. So we've done work with this organization, again, lower left-hand corner, it's linked, they're called HSS. So not to confuse it with Healthcare Safety Services, this is just HSS. That's their name right now, that acronym. And so we've done a lot of work with them in the past few years, actually, and I'll describe a couple different things. But first and foremost are the physical security risk assessments. So these are a little different than the workplace violence gap analyses that are focused more on, again, the culture, the people behavior, quote unquote, if you will. Whereas the physical security risk assessments through HSS are just that. They're more on the physical side. They look at the structure of the building. They look at lighting. They look at how many security cameras do you have? Do you have security cameras? Are they outdated? Are they, how often do they record? Do they loop, the recording, or is it saved in a cloud somewhere? Are they aimed at the right spot? When patients, visitors, et cetera, anybody comes into a building, are there metal detectors? Do you have a screening system? What's the check-in look like? Do people just have free access to different areas of the building? These are all things that go into the risk assessment. And it was really interesting, even things I've never even thought of after the first wave of MHA members went through this. And I was asking about how the process went and their feedback. And they were like, yeah, it was great. And there's stuff that, never would have occurred to me, like the height of the bushes outside your building shouldn't be longer than this many feet or taller than this many feet because somebody could hide behind it. And again, when you go back to that earlier statistic from the US BLS that I showed at the beginning of this presentation, a lot of these potentially fatal attacks do happen. They sort of spill over into the workplace from a domestic relationship. And so these are all things that you have to think about. They may know when this person gets off shift, or there may be some stalkerish behavior or something. I mean, that's a very specific example, but again, going back to taking a broad look at the structure of your building, your organization, and how can you put measures in place to shore up those areas that may be a little weaker in terms of protecting staff. So again, the physical security risk assessments, we've been doing these for a little over a year. We did them with 5 Michigan hospitals initially, all had great things to report, great experiences working with HSS. They are absolutely consummate professionals. And again, examines the exterior grounds, looks at physical security measures. The nice thing is that they take a very comprehensive approach to this work. So they will investigate the area crime report. They'll do an analysis to look at specifically within your region, the community you serve, what is the level of crime? Is it a high crime area, low crime, middle of the road? And that can help inform them when they do these assessments, how to prioritize different things that they're seeing and that they'll put in their report. And then, of course, they have recommendations for improvement. So that's the first offering from HSS. And then another new thing that we're just now rolling out to members is active shooter training. This is, again, through HSS. This is by far one of their most popular offerings throughout the country. And we received a lot of anecdotal reporting, you could say, to us, or feedback to us at the MHA, that this is a need of organizations. And a lot of you are probably contracting with companies to bring active shooter training to your organization, but this is something that we felt was a good addition to kind of the suite of offerings that we have under the Blue Cross partnership. So a little more about the active shooter training through HSS. They teach run, hide, fight. So that's probably not a huge departure from what you're used to hearing, but that is their philosophy that all of these trainings are rooted in. And they do a number of different levels of trainings. And so the first level, and these are all offered under our Blue Cross partnership, but the first level is large-scale virtual trainings. And there's pros and cons to each of these, certainly, that I can address. But the large-scale virtual trainings, they are just that. They're webinar-based, 60-minute, so 1 hour webinar trainings where they teach run, hide, fight, more classroom style. And they can offer this specifically to your organization or your system. And what that means is that if we work with HSS to bring it to McLaren, let's say, McLaren could choose to just do one training for one of their hospitals, or they could do one training for a grouping of their hospitals, or one for their entire system, but we won't mix hospitals and systems together necessarily. And the benefit behind that, and when I was speaking with HSS, this is what they said. They've had a lot of really great results, specifically in Alaska. They worked with the Alaska Hospital Association on this and on a similar way of rolling this training out to their members. It was highly successful. But what that allows HSS to do is tailor the content a little bit to maybe the geographic region of the hospital, or if you're a smaller rural hospital, which many of you are, that you have varying needs, many times very different needs than larger organizations that have a different pool of resources they can tap into. So it allows HSS to be able to tailor that coming into their training and sort of have answers ready that some of your staff or your leadership might be asking. So that's one benefit. Again, it's webinar based. Typically, they can schedule these a little more easily than, say an on-site presentation or an in-person activity. And you can train more staff. So just, cutting straight to the chase here is that you can touch more of your staff, and it's just easier with time constraints and everybody's busy. So it opens the door for a broader offering to your staff. Okay, kind of another level that they offer is in-person simulation. So this is where it's very hands-on, very interactive. They would send a team out to your facility, and they would be able to do up to 6 sessions, so 6 simulations within a 9-hour period. So basically within a full day, they could do this training 6 different times in 6 different locations within your organization. So many times what that means is HSS's team will go unit to unit to unit. They've also had organizations say, well, we don't want you just picking up your shop and going to different units throughout a 9-hour period. So they'll set up shop in one place and have groups of people rotate throughout that 9-hour period. But either way, they can do up to 6 sessions within a 9-hour period. I will say, because this always comes up, and we've had a couple organizations hesitate on going down this route because of the potential that maybe somebody doesn't know it's a drill, maybe because there's acting going on. It's built to elicit an actual emotional response. That's the idea behind the training, is kind of building that muscle memory. And so one thing that HSS does to try to get ahead of that is they provide you with email templates that you can send this language out to staff or through a community newsletter, et cetera. They provide flyers that can be posted up around the waiting rooms and on the floors, other language to notify staff. So they provide you with a lot of support and resources to make sure that everybody is aware that it's just a drill. If you see these things, it's not a real active shooter situation going on. Now, that being said, it's not like that couldn't happen, but HSS has never told me that it has happened before, and they do these trainings all the time, all across the US. They've never mentioned to me they've had a problem with that. So, but we always get questions about that. So how these active shooter in-person trainings go, and again, it's very hands-on. HSS, typically 2 employees of HSS as kind of observers, if you will be accompanied by an active or by a paid actor who will be the quote unquote aggressor. And so typically they'll present a scenario where, it's a family member and maybe their mom is in a room down the hall and they feel like they haven't been seen enough and they're being neglected and they're not being listened to, or whatever it might be. They're just frustrated because of different circumstances in life. So they start escalating and they get louder and they display these nonverbal cues, and they're getting agitated. And then this individual, what they do is they pull out a dummy handgun, basically, that does make a little clicking noise, a little popping noise, not loud, but it does make a noise, and they never point it at anyone. So it'll either be just pointed down at the ground or up in the ceiling, but they never aim it at anybody. But again, the idea is that it's a visual, it's sort of eliciting this response that you might have, this kind of fight or flight thing. And the idea behind that is that if you don't have that muscle memory when it actually happens, and hopefully that will never ever happen, but if it actually did happen where the scenario came to fruition, you do want that muscle memory to be able to take over and push your body to run, hide, fight, and not just freeze up like deer in the headlights. So that's the idea behind it. And then they look at the responses. So this aggressor is has this dummy gun out, and the staff then have to employ what they've been taught, run, hide, fight, etc. The 2 HSS observers are taking notes, and then there's a debrief that happens afterwards with staff, and there's never any finger pointing. There's never any, oh, that was dumb. Why did you do that? Why did you, just sit and hide right here in plain sight? Of course they can see you. That's not at all the feedback that they get, but instead it's just constructive. What was your thinking behind this? Maybe, you could have done this instead. And they always say, HSS says that no matter what, every time there's always one staff member who still tries to de-escalate and talk down the aggressor after they pull this dummy handgun out. And at that point, they should have been long gone. So there's always learning opportunities here. And then one other thing I did want to mention is that they do, in the unit or wherever they're doing these trainings, they use blue tape. They tape off a box somewhere off to the side. That's the safe zone. So if anybody does not want to take part in this, but they're at work, they're on the unit, they can't really leave, they can stand in that box and they're basically invisible to the staff, to the trainers. So there are steps in place that HSS put to try to make this a better experience for those who may be traumatized because of some past experience or just not want to participate in it. So that's definitely the most hands-on training they offer. And then the third offering is, and it's kind of in the middle, is an active shooter incident management tabletop exercise or incident command team exercise, where it is in person. They will sit down with you, with your team, go to your hospital. But again, they're sitting down. It's not active shooter. There's no dummy handgun or anything like that, but they walk through with the management team. So again, it's not all frontline staff. It's just the incident management team. and they walk through what would your response be organizationally at various levels in the situation of an active shooter. What would happen? What are your lockdown policies? Do staff know what to do? Do they know where to go? Do they know what to do with the patients? What does your infrastructure look like? Policies and procedures. And they walk through this scenario and provide feedback that way. So that's also a useful exercise. And I did put on this last bullet point here. It can be done in conjunction with the live simulation. So you don't necessarily have to only do one or the other. Especially with smaller hospitals, we've had a lot of suggestions of, well, you were offering 6 different active shooter simulations throughout a 9-hour period. We're such a small hospital, we might only want 2 or 3 different locations. But then we'd like to follow it up the next day with a tabletop exercise to kind of incorporate some of that information. And so that is an option as well. And again, I did put in parentheses, that would turn it into a 2-day affair. So that type of stuff does factor into pricing, which again, you wouldn't see, but we don't have limitless funds. So we do try to be strategic about allocating this and potentially grouping hospitals where HSS could come in one trip so they don't have to travel out to Michigan 2 or 3 times. So that all does kind of factor in. Again, that's information for us on the back end, but it does help extend this funding a bit for the good of the group. So how can you get involved? If any of this interests you, so the physical security risk assessment, the active shooter trainings that's newer that we're rolling out, or the workplace violence gap analysis, and actually HSS does even offer things like de-escalation training. So you can, I didn't go over that here, but, and it's not something we've historically done with the Blue Cross funding, but it's not out of the question. We have some flexibility with how we can work with our partners. But if any of that interests you, you want to learn more, or you'd like to sign your organization up for something like this, here are the basic steps. Just email keystone@mha.org. You can also reach out to me directly. That's fine as well. My email is on the last slide, but a surefire way that I'll see it is to email our general Keystone inbox. At that point, when we get an idea of what interests you and what you might be looking for, we will connect with the appropriate subject matter expert or company that we're working with and get a call, typically with you and your team, whomever you think should be at the table, and then the person from HSS or Healthcare Safety Services or whomever else we're working with to kind of do an introduction and provide more technical details that I can't answer, for instance. And then if we do get a group of several hospitals, we can arrange for group calls as well, where it's more of an informational session. So if there's interest there, we can arrange that. At that point, we will confirm, again, the funding for the scope of work. So a lot of the offerings do depend on, okay, this group's coming in, or they're flying into Michigan to provide this training in the Lansing area. Are they coming in to do the training with one hospital? Are they going to hit multiple hospitals throughout the week? Do you have, if you're a system, maybe we'll only be able to provide funding for 1 or 2 of your hospitals versus every single hospital. So again, we try to take a very fair approach. We look at who's been active in the past and who's willing to engage with us moving forward. Those all kind of go into the decisions of getting the green light from the MHA side. And so once that's approved, the scope of work, if you will, approved by the hospital, obviously all of your leadership on board to give the green light, and the Keystone, the MHA side, then we'll begin scheduling that. Currently, a lot of these services are being scheduled 2 months out at the earliest. So just to give you an idea of the timeline. So we're obviously not looking at doing anything for the rest of this year schedule wise, because there is a long list of hospitals throughout the country that are seeking these services. So just an FYI there. And the only requirement we have of you to get these services is to provide us your OSHA data. So again, that is in our data platform called Key Metrics. And basically all we ask for is the number of incidents per month in a few different buckets of harm. So again, violence, obviously, slips, trips, falls, sharps, things like that, and the total number of staff hours worked for that month. And then we will go ahead and automatically calculate your OSHA recordable incident rate. And that helps us drive this work, be able to allocate the Blue Cross funding and other resources to the areas of greatest need. So that's our only requirement of you, if you'd like to take advantage of these services. So that kind of sums up the deeper dive into our Blue Cross funded workplace violence specific work. Happy to answer any questions. And I did put a few prompting questions on here just in case we had extra time, but it looks like we're kind of right on time with 9 minutes left. So happy to answer any questions, and I'll take a peek at the chat too. Oh, good feedback on well-being. That's great to hear. And it looks like there was another question probably earlier on about the standard penalties. The standard penalties apply to patients. Yes, the original normal penalties do apply to patients in terms of, like, I think, for instance, the assault and battery would be up to $1,000 fine if you assaulted a healthcare worker. If you are not a patient, if you are a patient, it could still be up to $500. So those laws do apply.
Adam, I can just speak for a minute on our experience with HHS and the security risk assessment that we had done last January. We are still rolling out our action plan on that, but they just had such valuable perspectives with their different backgrounds coming in that we've changed some lighting outside. We've changed some door films so that they can't see so much inside. One of the things that they did is come on site in the dark and look in our building to see what they could see. So where we had risk there, they went to all of our outside clinics and looked around at them as well. We've added some door closures to those clinics to make sure that those doors do close behind them. And their three top recommendations was, of course, de-escalation training, which we have recently completed, and it was very well received by our staff. And then having a security response team trained and ready to go. So we have that in place, and we're working on getting our first drill in place as well. So that's something that's going to be new for all of us. We've added a couple of security cameras. One of their other recommendations was, of course, security on site, especially on those nights and weekends when we may have only 6 people on board, but that's proving to be very difficult to find something to meet our needs, but we continue to interview for that. And we've just decided also on a mass communication system so that when there is something that needs to go out to all staff, we can use that. And we just had an example where we had a partial lockdown because we had a visitor that was threatening while there was a patient in the emergency department, and there were staff that came in during the night while the patient was still there at 4 and 5 in the morning who didn't know about that lockdown, who could have been a little bit more vigilant coming in had they known. So that's just an example of where that mass communication, the text going out to everybody could have been very beneficial. So we have taken away a lot from that assessment, and we really appreciate it.
Great. Thank you so much for sharing that, Jen.
Mm-hmm.
It's excellent.
That's okay.
So I'm not seeing any other questions, but if anybody's willing to speak to any of these questions on the slide, please by all means do so in terms of your biggest areas of concern with workplace violence. One that I've heard, because when we hear workplace violence, a lot of times our minds go to the mass shootings, active shooter, like the really, really severe but relatively rare things, high catastrophic, absolutely. But there's so much more to violence. There's the slapping and the scratching and the hitting and kicking and pulling and pushing and, yelling and the verbal part. And one thing I've heard over and over again over the last year, certainly, is that a lot of times staff members don't know what they should be reporting. They don't know maybe that that organizations want them to report if somebody said a swear word at them, or somebody, grabbed their shirt and yanked on it, or lashed out because they're frustrated, and kind of changing that cultural mindset of this is not okay. This, this should be reported, to analyze and improve based upon that. And I realize there's more things that go into it, but that's just one sticking point I've heard recently. So just curious if anybody else has input.
Adam, this is Heather Schrag at Eaton Rapids. Can you hear me okay? Okay, thanks. So this is one of our goals, is to increase reporting on workplace violence incidents. And one thing that we noticed is that we would hear people talking about it a lot, that these incidents were occurring, but we weren't getting the incident reports to back it. And so it's actually one of our goals this year, our overall hospital goals, is to increase reporting, because we can't really address it if we don't have we know it's happening. So it's not that, we can't address it if we don't know about it, because we do know about it. It's the documentation piece, because
Right.
It's, and I don't want to say like the boy that cried wolf type of thing, but it kind of is, because if you keep talking about it, but there's nothing like substantial behind it for us to act upon, how can we properly address it? So if we're just hearing about it, word of mouth, if I have nothing substantial to act on, that, it's happening in this department or that department, and these are the key times, and this is what's happening. So it started with defining what is workplace violence. So getting those key definitions. And like you said, it's not always about the physical harm. It's the verbal aggression. It's that psychological safety. And so those are some key drivers. And all, like listening to your presentation, I found myself like nodding, yes, 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 agreeing, because we have had in the past, and we're actually dealing with right now, a current staff member that is dealing with a domestic situation, and, constantly needing, we're moving where this person parks, making sure that they're being escorted, to and from their vehicle, like just different things. And it just takes on a whole nother life of its own. There's just so many things, but even in our most recent survey, so we do pulse checks every quarter, and some of the comments were, it happens so often that we don't even think about reporting it, because healthcare workers accept it. They think that it's part of the job. It's not part of the job. And so it's kind of like retraining people that this is not okay. You wouldn't accept it somewhere else. So why do you accept it at work? It's not okay. It's never okay. And, I tell people, I'll bring my laptop, I'll sit in your department. And when this happens, I will stand up for you. Like, I'll be that person, your voice, because it's just not okay. It's not part of the job. And like, how do we retrain people to say that? Like,
Yes.
yes, I will go to my grave, like fighting for our people. Like, it's just not okay. Like, I think about Jen Monzo's story about that individual that came to her hospital and like broke through the glass. And I just don't know where like we've left in our society, that people feel that this is okay to accept this behavior at work. It's not okay.
Right. Yep. Definitely. Yeah. Thanks for sharing that, Heather. I completely agree with you. It's an uphill battle for sure. So, yeah. you know.
Oh, Adam, one other
Yep.
thing I wanted to just tell you,
Yeah.
another takeaway from our pulse survey
Mhm.
is, people say, not only do they feel like it happens so much that they're like, I'm not gonna report it happened so much, but they say it takes too long to report. So one thing for us, yes, we're paper and we have like a makeshift homegrown like reporting where they can do it online, but it doesn't matter, like, they're still saying, whether it's on paper or I can go to my computer and enter it online, it takes too long to report. So, why report it? So I tell them, I don't care if you just send me an email. You send it to me on a Teams message, you text me, you write it
Right.
on a sticky note and put it in my mailbox. I don't care. Get me the information. I need to
Yes.
know. So I don't know, it's an uphill battle. So if anybody has suggestions, please tell me.
Yeah. Yep. That's why we're here. That's why there's groups like this. And I know we're over time, but I did see that last remark, so thank you for sending that. I noted that.
Alright, well, thank you everyone for joining this afternoon. Again, Adam, thank you so much for presenting again to us today. Everyone have a great Tuesday afternoon, and we will see you at our next open office.
Thank you.
All right,
Thank
thank
you.
you.
Bye.
Bye-bye.